So with all these medication improvements, from a patient education perspective, what are the key challenges? What do we
Yeah,
have to
the
be concerned
challenges are, just as a backdrop, the American Association of Diabetes Educators has an evidence-based curriculum called the AADE-7, which are the 7 evidence-based key behaviors to ultimately control blood glucose and reduce the complications, which drives cost up. And one of those behaviors is medication. So when you have these very novel, I call them designer medications, and the combinations and the unique dosing devices, sometimes they have to be mixed and you have to pull this lever and do this with the pen. It takes more time. And so you have to subtract that time from the eating intervention, the exercise intervention, the psychosocial coping, the monitoring. So it presents a challenge. But the bigger challenge, and I have to say this, is providers actually referring patients to us to get all of this education. Where when providers try to do the medication education in a 10 or 15 minute E&M appointment, that is very difficult for the patient.
Yeah,
because of literacy and numeracy issues, and the providers trying to squeeze in that education on these designer drugs, it's not a good situation.
I think diabetes educators are terribly underutilized, and it's really a shame. You know, we have the luxury at Joslin of really all of our patients seeing diabetes educators, and firmly believe that that's a big part of why our outcomes are as good as they are.
Do you feel me hugging you right now?
No, really, I think it's a big issue, and it's more than just reimbursement, really, because even when in places where they are reimbursed, and there is reimbursement, they're still underutilized. And so I think many providers may not realize the benefit, and also I think patients probably don't like the term education. Like, you graduated college or high school and you're done. I don't want to do any more education.
No more education.
You know, coping skills, helping you to live better with diabetes. Those kinds of things are probably nicer ways of framing it.
We certainly don't want to lose the behavior modification in light of sort of all the complexities of how to take your medications, right? So, well, this has been a great discussion. You know, we could go on longer as we did on our prior panel. Thank you all for joining me. What I'd like to do is give each of you some final opportunities to make a few thoughts. And Dr. Bloomgarden, I'll start with you.
Well, so I really appreciate the opportunity to be here. And I think we've gone over one of the really crucial areas of treating the person with diabetes, sort of at the further end, not the most advanced end of disease, but people who really need a lot of medications, such as these 2 injected medicines that we discussed, insulin and GLP-1s. And these are people who cannot be treated in an easy, inexpensive, simple fashion that doesn't require a lot of help, which one might call education, or one might choose to use another term if the individual doesn't want to say, I already was educated. But every healthcare provider, although I like to say every doctor, but because it's, the term provider is so commercial sounding, but every one of us who tries to treat people with diabetes feels that this is a human being who's struggling with this disease, who's struggling with the lifestyle changes, who has so many choices of diet, food availability, lack of desire to exercise regularly, the need for these expensive medicines. So I just want to emphasize that we really can help people by using these newer treatments. And of course, the managed care companies have helped us to make it available, even though we grumble a lot. Without insurance companies supporting the patient's use of this, we could never do it. So it's a challenge.
Great. Dr. McBay.
I think really, given all the choices that we now have in terms of managing diabetes, we can really individualize care much more effectively based on what the needs of that patient are. And we talked about a number of factors to consider: hypoglycemia and weight gain and other comorbidities. I think, the big studies that are done mix lots of groups of patients together, and to really tease out the benefit of some of these newer agents, it's probably subgroup analyses or studies that are designed to look at different subgroups. That said, it's terrible that insulin has become unaffordable for patients with diabetes, and I think as a society we need to do something about that, and the first step is to be more transparent about what goes into determining that large rise in price that's occurred over the last several years. And that said, I think there's so much improvement that can be made in diabetes care, and we have so many more tools to be able to do it now than ever.
Mr. Horowitz.
And I just want to say, I'm going to use the analogy of the AAAs. Insulin has to be, in all its forms, in all its devices to inject it, for the patient, has to be affordable, accessible per the payer, and the mail order pharmacies, and appropriate, individualized for the patient's unique lifestyle needs, metabolic needs, complication needs, affordable, accessible, and appropriate.
And Dr. Snow.
And we need to make sure that that it's being utilized as frequently as it needs to be. For type 1, in a way, it's easy because it's absolutely essential for life. But for so many folks with type 2 who clearly have a need to move beyond the therapy they're on to achieve the level of control that they should be, insulin is still, almost 100 years later, a wonderful drug and needs to be available for those folks so that they can achieve that control and stay healthy.
Agreed. Well, I want to thank you all for joining in this discussion. And on behalf of our panel, we thank you for joining us for this AJMC Peer Exchange.